Welcome. Thanks for joining us for our webinar on understanding chromophobe renal cell carcinoma. I'm Annamaria Scaccia. I am a board member of COA, and here with me today is Katie Coleman, founder of COA, and Dr. Pavlos Msaouel, a leading expert in kidney cancer. Today, they'll cover everything from risk factors and prevalence to the latest research and clinical trials. This session is being recorded and we'll have a Q&A at the end. So drop your questions using the Q&A feature anytime. And as we mentioned, please leave the chat for conversations once we have it not disabled. And so that is my spiel. I will be off camera and I will be turning it over to Katie now for the interview.
Thank you, Annamaria, for joining us and for the intro. And for those who don't know, Annamaria is our newest board member at COA, so we are very excited to have her as part of the board. And we are even more excited to have Dr. Msaouel joining us here for our first webinar with COA covering Chromophobe 101. Thank you, Dr. Msaouel, for joining us today.
Thank you for having me.
So to kick us off, I thought we'd start with just the basics and a high-level description and overview of chromophobe kidney cancer and how it may differ from the other types of kidney cancer, such as clear cell, which is the one that we most commonly hear about.
Yeah, so chromophobe kidney cancer is the third most common of the kidney cancers. Clear cell kidney cancer, as you mentioned, is the most common one. And it is a kidney cancer that was first described in the mid-1980s. And it's actually called chromophobe because often the cells of that kidney cancer can look pale under the microscope, hence the name chromophobe, which essentially in Greek means fear of color, the cells looking pale. So that's a little bit different than clear cell, where the cells look clear. Here, the cells look pale. And that differences in color actually signify also the differences in biology. So they are two quite a bit widely different cancers. One of the things that is different about chromophobe is that thankfully, in many cases, but not always, unfortunately, chromophobe kidney cancer tends to be more indolent, meaning less aggressive, less angry, less likely to metastasize, spread. However, when it does spread, it can be more difficult often to treat because it needs to be treated differently than the more common kidney cancer, clear cell kidney cancer.
I appreciate that overview for chromophobe, and you touched a bit on the prognostic difference between chromophobe kidney cancer, oftentimes in the earlier stage than some of the other types. Do you know if there are any known risk factors for the likelihood of developing chromophobe kidney cancer or kidney cancer in general?
Yeah, the risk factors for chromophobe kidney cancer have not necessarily been studied as much as for clear cell kidney cancer, but we do know a few things, and hopefully in the near future we will know even more. The first thing always when you think about risk factors is that every time somebody does end up developing a cancer, it's always a combination of three different things, always, for any cancer. And those three different things are genes, environment, and randomness, just bad luck. And so in some cases, it's always those three together that need to happen, always. But in some cases, it's more the genes than the environment. And in other cases, it's much more the environment. So sometimes for some people, they may have a genetic predisposition, and those are what we call the genetic syndromes, or the medical term we often use is the germline syndromes or germline mutations. And there are some of these syndromes. One of them is called Burgholz-Dubé, abbreviated as B as in boy, H, D as in David, BHD syndrome, which does increase the risk of various kidney cancers, including chromophobe kidney cancer. Then there is another genetic syndrome. It's called the Cowden syndrome, or otherwise known as the P10 syndrome. Again, these are very rare syndromes, but it is also associated with chromophobe type of kidney cancers. And then another one, a little bit more common as a syndrome, is the tuberous sclerosis syndrome, that is much less likely when you have it to increase the risk of chromophobe kidney cancer, but it can. So those are some of the established genetic risk factors that may be associated with chromophobe kidney cancer. With regards to other factors, we often think about differences in sex, and with clear cell kidney cancer or with other kidney cancers like renal medullary carcinoma, for example, they happen more often in men. So clear cell kidney cancer is about twice more common in men than women. But with chromophobe kidney cancer, we don't see that unevenness. It appears that it happens about equally in men and in women. There is another kidney cancer, also rare, more rare than chromophobe, called translocation kidney cancer, and one of its main subtypes, the TF53 translocation, is actually more common in women. So we have clear cell kidney cancer, more common in men, translocation kidney cancer, the TF53 one, more common in women, but chromophobe about equal. Then we know, for example, going now to environment, that with clear cell kidney cancer, there is essentially almost certainly an association with smoking. And that association is weaker, or at least we have not detected as strong of an association with chromophobe. So with clear cell kidney cancer, there's clearly or more clearly a connection with chromophobe, not as much. Then the other one from the things that we can tell, some of the kidney cancers, renal medullary carcinoma, abbreviated as RMC, is one of them, and papillary kidney cancer is another, that does, those two do tend to happen in the Black population. So they are a little bit more associated with specific race and ethnicity, whereas with chromophobe, we have not seen that, at least not thus far. Maybe there is an association, but it has not yet been established. So it does appear to be equally common among Caucasians, as in Blacks, etc. We also have an association between obesity and clear cell kidney cancer. Again, the most common kidney cancer. So I'm talking about the risk factors that you will often see being named because they have been studied for the most common kidney cancer. Really not as well studied for chromophobe. There may be a signal that BMI and obesity may be associated, but again, there is so much research that needs to be done to get a more clear signal with regards to that. And one last thing that I can think of is, if we know that if you have, even if you don't know that you have a specific syndrome, if you do have a general family history of family members that have developed kidney cancer, then your risk of yourself having kidney cancer increases. This does include potentially chromophobe kidney cancer as well. It's a less specific, let's say, risk factor than having a well-established syndrome like the BHD syndrome, Birt-Hoag-Dubé, or the P10 syndrome, but it still is considered a risk factor.
That's all fantastic information. Two follow-up questions on some of those categories. One of them is, you mentioned some of the genetic conditions like BHD and some of the others as well. Do we know what the prevalence of that is? Is it more common for someone who's diagnosed with chromophobe kidney cancer not to have a genetic history for it? And then my second follow-up question is, do we know anything about the age or demographics of chromophobe kidney cancer And is it the same that we would expect in the other types of kidney cancer, such as clear cell as well?
Yeah. So yes, if somebody does develop chromophobe kidney cancer, the highest chances are that they're not going to be found to have a specific syndrome. And that is because these syndromes are very rare. For context, the Burhoek-Dubé syndrome, it's, as far as we can tell, is 2 cases per million. So it's quite rare. Probably it might be more common than 2 cases per million. It might be a little bit underdiagnosed, but let's say it's double that, or more than that. It's still very, very rare. So if you have chromophobe, most likely you're not going to have that. Same, with the P10 syndrome or Cowden syndrome. It's like 1 in every 200,000 individuals, quite rare. And then, the tuberous sclerosis syndrome, it is more common. You will see it in 1 in every, let's say, 10,000 births. But it is much, much less associated with kidney cancer risk. So whereas with Burhoek-Dubé, you have, a risk, if you have that syndrome, of around, 10 to 20% in your lifetime to develop a kidney cancer. And chromophobe is one of the ones you could develop. With the tuberous sclerosis syndrome, the risk is less. It can be less than 5%. So even though it is more common, you may actually not develop kidney cancer. So what ends up happening in the end is that on aggregate, if you do develop chromophobe kidney cancer, more likely than not, you're not going to have, a syndrome. But having said that, if you do develop chromophobe kidney cancer and you are young, formally the cutoff that we use for guidelines and recommendations is younger, 47 or younger, then you usually do merit to have a genetic evaluation just to make sure there is no syndrome associated. Chromophobe, compared to your other part of your question, compared with clear cell kidney cancer, the most common one, does tend to happen in a little bit of younger patients. But it's not a huge difference. So let's say the average that clear cell kidney cancer can happen is, let's say, a median, we call this, of, let's say, around 61 years old. Chromophobe is in the range of 58, 59. So it's still not people who are typically in their 20s or 30s. So that is why if you do develop chromophobe and you're on the younger side, it may still be worthwhile, talk to your physician and have a genetic evaluation.
That's great feedback. And kind of sticking on the topic of genetic syndromes, I know another common terminology that patients might come across is they hear about genetic mutations, but they also may hear about like genomic mutations. And we hear language often as P53, P10 being common with chromophobe kidney cancer. Can you help explain what the difference is between germline mutations or genetic mutations and some of these other mutations that might be more common in chromophobe kidney cancer?
Yeah, that's a great question. So one way, easy way and informative way to break it down is that you can have 2 types of mutations, let's say. So one is what we call the germline, and that is the medical term, which means that mutation is in every cell of your body. So from birth, every cell of your body, your normal cells and your cancer cells, will have this mutation. It's everywhere. That's what germline means. And that is what's happening, that because every cell in your body have this mutation, if it does increase the risk of cancer, that's why certain organs in your body may be at increased risk for developing the cancer. And then the other term is what we call somatic mutations. That is the medical term. When we use the term somatic mutations, those are the mutations that happen only in the cancer cells. They're not in the normal cells at all. And so from the somatic mutations, there are some of them that happen more often in chromophobe kidney cancer compared with other kidney cancers like clear cell. And these types of mutations can give us also a clue about what's happening under the hood, what is driving chromophobe kidney cancer specifically to grow. So as far as we can tell, there are at least two big mechanisms, two pathways that drive chromophobe kidney cancer from the somatic side. These are the mutations that only the cancer cells have in order to drive them. One is what we call the mitochondrial dysfunction. The medical term is, they lead to the so-called oxidative stress. What is that? So the mitochondria are like essentially the power plants in our cells, and they produce energy through this process called oxidative phosphorylation, or OXPHOS. That's what keeps the cells running normally. And what happens is that in cancer, like in chromophobe kidney cancer, those power plants, the mitochondria, can get hijacked or damaged, and that OXPHOS pathway can speed up or fuel the growth of the chromophobe cancer cells, allowing them to adapt and survive through tough conditions. So that's one. And then the other pathways are mutations, somatic mutations in genes like the P53. That's the one that you mentioned. So P53 is a gene that acts very much like a guardian in our cells. It actually helps normally to prevent cancer by stopping cells with damaged DNA from growing out of control. That's what P53 does. And, the term can either be T as in Tom, P as in Peter, 5-3, or sometimes we call it P. We start with the P as in Peter, 53. So you hear me using either term. It's the same thing. So when you get this somatic mutation in P53, it loses its ability to do its job. So now it may allow these damaged cells that have, the damaged DNA to potentially turn into cancer, or if they are already cancer, no matter how much they damage their DNA, they'll still keep growing. P53 mutations are actually found, or changes in general are found in about half of all cancers, which makes them a key player in understanding and fighting cancer overall. But interestingly enough, you don't see them in the way you see them in chromophobe in, let's say, clear cell kidney cancer or other cancers like renal medullary carcinoma, etc. So understanding why chromophobe in particular tends to have mutations in P53 may give us some clues on how best to develop therapy specifically for chromophobe. Another one that you will hear, that's the last one of the big ones that you might hear about, is the so-called P10 mutation, which I alluded to because, as I said, you may have a germline mutation as well. That's the germline, the P10 syndrome or the Cowden syndrome, which increases your risk for developing chromophobe. But at the same time, even if you don't have that germline syndrome, your chromophobe kidney cancer may somatically develop the somatic P10 mutation, which activates certain pathways that regulate or change how the chromophobe kidney cancer uses energy based on signals like nutrients or stress. The related pathway that people might hear about is the so-called mTOR pathway, M as in mother, T as in Tom, OR. So when you get a somatic or a germline mutation in P10, that puts the on switch on this mTOR pathway, which changes how the cells use energy based on nutrients or stress, as I mentioned.
And I'm sure we'll loop back to talk about mTOR a little bit when we talk about the treatments available for chromophobe kidney cancer, because I know there are a few that target mTOR. But now that we've covered kind of some of the mutations associated, let's zoom back out and talk about chromophobe as a whole. We know chromophobe is about 5% of renal cell carcinomas diagnosed. How common is it for those to become metastatic? Do we know any statistics around both the prevalence of chromophobe kidney cancer as a whole, again, kind of that 5%, and then of those numbers, how likely is it to become metastatic or spread?
Yeah, so chromophobe is the third most common kidney cancer, as I mentioned. It's about 5 to 10% of cases of the total of kidney cancer. In children and young adults, it's the most common of the renal cell carcinomas, the most common types of kidney cancers, about 6 or 7% of cases. So that's why it is not as common in younger people. And what happens is that, as I mentioned, thankfully, in most cases, it doesn't spread. So in most cases, it will not go to other organs. It will not metastasize. What are the exact numbers that it will metastasize? Probably in the range of, I would say, 10%. So about 10% of cases will end up spreading. I would say, or to be more fair, less than 20%. Less than 20% of cases will end up spreading. So that is good news compared with other cancers. So, for example, renal medullary carcinoma, almost all of them spread. Clear cell kidney cancer is also more likely to spread than chromophobe. So that is a difference of chromophobe.
And so when it does spread, what are the treatment strategies or the treatments that are available for treating chromophobe kidney cancer? And what do we know about kind of which ones are most commonly used for patients?
Yeah, I often say that to patients, that a good way in oncology, cancer medicine, to break down the therapies in these two big buckets. One of them is the localized therapies or local therapies, which are the therapies that address the cancer in a specific area. So surgery is a localized therapy because you cut out what you can see. Or radiation is a localized therapy. You can irradiate a specific area. You cannot irradiate the whole body, at least not for kidney cancer. Or you can burn the cancer, you can freeze the cancer, or you can do another procedure called an embolization or ablation. All of these are different ways for providing a localized therapy. So once we decide that a localized therapy or local therapy is the way to go, then we decide which one to use, surgery or radiation or burning the cancer or freezing it or whatnot, depending on the anatomy, depending on what we have the most data that it can be beneficial. And then there is the other big types of therapies that are called systemic therapies that come from the word system. And these are the therapies that go all over your body to recognize and kill cancer cells, hence the name systemic therapies. And they're different because, again, when the cancer has spread and it is stage 4, that does mean that it has access to all of your body. And so sometimes, for patients, they say, oh, it's only, in one area and maybe nowhere else. What happens is that when we do imaging, and imaging is the only thing that we have to know how extensive chromophobe is, if it has spread, a CT scan, for example, is a good way to image it, and it can detect things that are very, very, very tiny, like 1 millimeter in size, like very, very, very small. But in order for the cancer to get to 1 millimeter in size, you need to have millions of cancer cells there. Millions. So you can have hundreds of them or thousands anywhere in your body, and we cannot see them. That's why we may need systemic therapies that can potentially address all the cancer cells that we cannot see that could be anywhere. And from the systemic therapies, there are 3 big types that are useful for patients with kidney cancer to know. The first one is the old school chemotherapy that, we may give for patients with some breast cancers or prostate cancer, etc. They don't work at all against chromophobe kidney cancer. They don't work against clear cell either. They work against some other types like renal medullary carcinoma, but not against chromophobe. So that's out. There are 2 other big types of systemic therapies that can work against chromophobe kidney cancer, but not as well as for clear cell kidney cancer because they were developed for clear cell, not for chromophobe. And those are the immunotherapy, which is usually given through an IV. And what it does is it's different from chemotherapy. Chemotherapy is something toxic, but immunotherapy, its purpose is to stimulate your body's immune system to recognize and kill cancer cells. And so that's the goal with chromophobe. Chromophobe is very good at avoiding the immune system. So the chances of the immune system recognizing chromophobe are much less than they are for clear cell kidney cancer. But it can definitely happen. I've seen it happen. And when it does, it's very gratifying. And then the third type of systemic therapy that can work is what we call targeted therapies, which often come in the forms of pills. That's why a lot of patients call them chemo pills, but they're not exactly chemo because they're not indiscriminately toxic. They actually target certain molecules that the kidney cancer cells express. The challenge, again, is that those targeted therapies were predominantly developed to target molecules expressed by clear cell kidney cancer, not necessarily by chromophobe kidney cancer. That's why we need research to make targeted systemic therapies for chromophobe kidney cancer. But broadly speaking, those are the options. So this is every oncologist that has to manage a stage 4 chromophobe kidney cancer, or even an earlier stage. Those are the options, because if you have an earlier stage, then you're going to do a localized therapy. You don't need a systemic therapy. If you have a chromophobe kidney cancer that has spread, one of the data that we're generating through our collaborative efforts in the United States around the world is that, because thankfully very often chromophobe does tend to be less angry than clear cell kidney cancer, localized therapies, even in areas like the liver, may actually be useful. So we rely on them more than we would have otherwise. And another rationale for that is that we know that systemic therapies are less likely to work for chromophobe than they are for clear cell. Having said that, how you manage each particular case, it's very, very, very individualized. And this is why people should talk specifically to their oncology team. And if the oncology teams have any questions and they want to hear from our experience, we're always available. People definitely know how to find us, and I'll be happy to provide information on our latest approaches.
That's really helpful information. I know that when we talk about immunotherapy, one thing that has come up, especially in the last year, is adjuvant treatment. So treatment after the tumor or cancer has been removed and before it comes back. That has been introduced with immunotherapy in clear cell kidney cancer. And one of the common questions we see from those diagnosed with chromophobe is immunotherapy recommended for them in that setting? Can you speak a little bit to that from what we know about the biology of chromophobe and using it in an adjuvant setting?
Yeah, exactly. So the adjuvant setting is exactly as you said, the fancy medical term of saying, oh, I have had a therapy for my cancer, like usually surgery, for a cancer that I think is localized. I think it hasn't spread, but I don't know, because exactly there could be hundreds or thousands of cancer cells anywhere, and we cannot see them. There's no way to see them. There is currently no blood test. We're working on it, but right now, nothing that can reliably detect chromophobe in the blood. So we're relying on the images that can only see things if the cancer cells in that area are millions. So you can have hundreds or thousands of them, we cannot see them. So when we're in that situation where everything that is visible was removed, usually by surgery, the medical term is nephrectomy, removing the kidney, but there might still be cancer, which if those cells keep dividing, that's when the cancer comes back. They keep dividing until they become millions. Now they're visible. Now we're like, oh, it's back. It was always there. It's just that we couldn't see it. So the adjuvant setting is this scenario where we don't know, is there cancer or is there not cancer? We don't know. It's essentially a declaration of our ignorance. And so what we sometimes do in patients who, again, we don't know whether they have the cancer or not, but we think that they have a very high risk of having it. And how do we know? Based on how the cancer looked in the kidney after the surgery, if it has what we think are these aggressive features, like these things that we look on it and they tell us, oh, this is a more angry cancer than others. So if you are at high risk for your cancer coming back, we may give systemic therapies, and that's what we call adjuvant therapies, adjuvant systemic therapies, to hopefully eradicate those cancer cells that you may or may not have, and so that the cancer doesn't recur. Now, the trick here is the following. First, we don't know if you have them. So that even under the perfect circumstances where we knew that immunotherapy, the one that is approved for clear cell, for kidney cancer overall, and used predominantly for clear cell kidney cancer, even if it worked 100% in Chromophobe, which it definitely doesn't, you still don't know if you have the cancer. And the problem with these therapies is that they have potential side effects. So sometimes these side effects can be permanent, not always, but they can. And occasionally, very rarely, but we've seen it happen, they can even be deadly. So imagine not having the cancer, and we don't know, and then getting that therapy and then dying from the therapy. So this is a difficult dilemma. This is not an easy thing where we can say, oh, this is the best strategy. Even in clear cell kidney cancer, where we have the most data. In chromophobe kidney cancer, the problem is that the systemic therapy approved as an adjuvant, the immunotherapy, which is an immunotherapy drug called pembrolizumab, we know that it doesn't tend to work that well. How do we know it? Because we've tried these types of therapies in the stage 4 setting, and they just don't work as well. Like less than 10% of patients will respond, which is much less than clear cell kidney cancer, where you see about half of the patients respond. So the potential benefit is unfortunately much less, but the exposure to the side effects is exactly the same. So because of that equation, many in just about most circumstances, clinicians will not offer it. But again, it's a personalized decision. Some circumstances are different than others. But this is the reason why you're not going to be seeing adjuvant immunotherapy given for Chromophobe nearly as often as it may be given for clear cell.
And I know that this area is often something that a lot of patients worry about, especially since Chromophobe is much less likely to spread or become metastatic. The majority of patients won't ever have it come back, but there's always that worry. And I think there's a lot of concern when you watch there being other treatments to prevent the likelihood of it coming back in other cancers. So one question that we get quite often is, are there any actions that patients can take if they're diagnosed with earlier stages to help reduce their chances of it coming back? Or is there anything in development to try to help those earlier stage patients who may not have had a recurrence yet?
Yeah, and I completely understand it. You always want to feel like you're doing something. And I wish, we had the perfect strategy. I think a reasonable strategy is to monitor. That's what we call the surveillance strategy. Again, with the imperfection of our images, I already mentioned, they are not the super high resolution where they can detect hundreds of cells, but at least they can detect it when they're 1 millimeter in size or bigger. And what happens is that we do decide how often we're going to do these images, because the images themselves, it's a trade-off. They expose you potentially to radiation, or they're logistically challenging. You may have to travel, many miles away and take time off to do those things. So because of that trade-off, we're careful how often we use them. So in patients who we consider to be lower risk, and how do we decide that risk? Depending on how big the cancer was. If it was small and it didn't look that angry on the pathology, then we consider those patients to be low risk. So we may be doing checkups, once a year for, let's say, for 5 years. That's a number that we like to use, but it doesn't always have to be that. Whereas if it's like more high risk, bigger tumors that had invaded more areas in the kidney, and they looked very angry, we may be doing more frequent checkups, like every 3 months initially. And then as time passes, we may spread it more. And that, I think, is by far the most reasonable, plausible strategy based on our data. Like, that's something worth doing. Now, with regards to other things, we have to be very general, because again, if we knew that there was a very, very specific strategy that will help prevent it, we would tell you, but we're not yet that smart. And the problem is that when somebody says, oh, I'm going to adopt this lifestyle strategy because I believe that this will eradicate my cancer, we don't know if it's actually being counterproductive. It's exactly because we don't know. Like, a certain strategy may be beneficial, but it may be harmful. We don't know. So that is why the general recommendation is just adopt a healthy lifestyle, which will help you regardless. Like, regardless of what it does to the cancer, will help you in general. A balanced diet, exercising regularly, avoiding tobacco, all of these things that you will hear from any clinician saying. Do the age-appropriate screenings for, Chromophobe and other cancers potentially, and generally work closely with your health providers, and follow their recommendations, and always discuss them with them, so that you feel more confident in your surveillance plan.
That makes a lot of sense, especially since we talk so much about how the biology of chromophobe kidney cancer and all of the different subtypes of kidney cancer can be very different. And so it could be really difficult to take something into context, and you may see different behavior from different things that are tried. So I think that's an excellent point to share. So as we were talking about, one of the things you mentioned is the tumors that look really angry or aggressive, kind of under the microscope. Are there any known characteristics for chromophobe kidney cancer that make them more likely to come back?
Yes. And we're still learning, of course, exactly to refine our understanding of this. But one of the ones that we know certainly increases the chances of the cancer coming back and being more angry is what we call the so-called sarcomatoid changes. And what is that? So as I said, we call chromophobe because it has a certain appearance under the microscope. So it looks pale under the microscope, etc. And clear cell, again, we call it because the cells look clear under the microscope. But what happens is that the cancer cells, as they keep growing and dividing, they may start evolving, and they may change to start looking like something else. And if they start looking like another type of cancer called a sarcoma, they're not a sarcoma. They just look like a sarcoma. They're chromophobe that evolved to look like a sarcoma. Then the medical term we use is sarcomatoid. And what is that telling us? That's telling us that it's the type of cancer that likes to change, likes to adapt to its environment. And you don't like things that are good at adapting, because they are tougher to treat. So that is a warning sign. Then there's another feature that you can see in the pathology. We call it necrosis. That's the medical term for saying that, at the certain areas of the cancer, a lot of the cells were dead. And counterintuitively, that can be a bad thing to have, because it might imply that there's so many cells that are dividing that they're utilizing all the nutrients there, so that's why they start dying, just because they're dividing so fast. So those are two of the really big ones that we know for chromophobe thus far. Ask me in a few years, I'm pretty sure we'll be much smarter, and we're working on it, and we're pushing actually to be much smarter. I expect that one of the things we're going to start incorporating is potentially the type of somatic mutations. So, for example, it's possible, but we don't know yet fully, that the patients that have these p53 mutations, their tumors, if their tumors have these somatic p53 mutations, they may be more angry, but each mutation is different, including on the same gene. So some of these p53 mutations may be just passengers, not really bad guys or whatnot. Others might be more of a warning sign. We don't know yet which ones is which, but we will find out, I promise.
And that's shows the importance of research in general and moving it forward. And we're very grateful for how much Chromophobe has started to move forward in the past few years. And there's been a lot more engagement and excitement around it as well. One of the things talking about ways to kind of surveil or see either response to treatment or coming back. I know that you recently had a biomarker that was discovered for renal medullary carcinoma, RMC, which you've mentioned earlier. That is a biomarker that's tracked in the blood. Do you know if this is something that is being explored for chromophobe kidney cancer or any of the others? I know RMC ended up being kind of the first one that had an official biomarker. Is that an area you see worth exploring in the future for chromophobe?
Yeah, and RMC unfortunately is the deadliest of the kidney cancers. It's almost always bad news to have it. And it actually has the extra challenge that for various reasons, it's a long story why it tends to afflict African Americans or people of African descent and who carry a certain blood disorder called the sickle cell trait. And see, this blood biomarker that our group identified is called CA125. That about 60 to 70% of patients with RMC, renal medullary carcinoma, their tumors will produce it, and so that their tumors will produce it. They'll spit it out, and it will go to the blood, and it can be measured in the blood and used to tell us how well a patient is responding to the therapy or if the cancer is coming back. It's kind of similar to how PSA, for example, is used to monitor prostate cancer. So this was, even though, as I said, RMC is in many ways bad news, there is actually now much more hope than there was even 5 years ago because of research. So there have been dedicated clinical trials that for RMC specifically, and now dedicated therapies for these cancers. We're now even able to cure up to 10% of these patients, and all of them are essentially stage 4, which a few years ago was completely unheard of. So in that same way of accelerating progress, now we see that RMC is essentially the first kidney cancer where we have a biomarker that can be used anywhere. So most places, can use it, and 60 to 70% of these patients, express it, so it can be used. It is not, CA125 is not expressed by Chromophobe, so we cannot use it for Chromophobe, but we are actively researching other biomarkers for RMC and other kidney cancers, including Chromophobe kidney cancer. And it's not just our group, there's many groups, both around the country and around the world that are doing a tremendous job trying to crack this, and we will crack it, both for Chromophobe and for clear cell. And we will get more biomarkers for RMC and the other cancers, because ultimately the goal is to give patients and doctors a simple way to track progress and make treatment adjustments sooner if needed.
So I think that actually feeds perfectly into our last question before we'll turn over to the Q&A, which from everything that we've heard about Chromophobe so far and the work that you're aware of that's currently being done or in the community, what do you think are the most exciting advancements, in your opinion, for where treatment or research may be heading for Chromophobe kidney cancer, and where do you see it in the next 5 to 10 years?
Yeah, so one of the most exciting areas right now is learning how Chromophobe kidney cancer is both similar to and different from other cancers in terms of its immune system interactions that we alluded to, and its unique metabolic and other fingerprints. Because that understanding will help us develop immunotherapies and other therapies that will work finally for Chromophobe. So we're very focused on developing what we call biology-driven therapies, treatments that target the specific mechanisms that make Chromophobe kidney cancer grow and spread. And so over the next 5 to 10 years, I see research delving deeper into these molecular details, getting us better tools to predict how its tumor will respond to certain treatments. And in my lab, in collaboration with Dr. Nikki Millworth and our urologic oncology trainee Liz Ellis and others, both at MD Anderson across the country, we are working to uncover what drives chromophobe kidney cancer at a genetic and metabolic level and pinpoint new ways to treat it. And it is by connecting these findings to how the tumor interacts with the immune system, for example, we hope to build therapies that are both more effective and gentler on patients. And this would mean essentially, hopefully in the next 5-10 years, a shift away from the one-size-fits-all approach of, we take the therapies developed for clear cell kidney cancer and we just throw them at chromophobe. Instead, we need more personalized therapies for each patient's tumor biology. Another thing I alluded to is, these sarcomatoid chains, which is a big problem for those patients with chromophobe that do have it. That is a big unmet need. So we're really working hard in our group and others to understand why this happens and why this variety of chromophobe is particularly resistant to current therapies, which may help us develop treatments specifically for this. And, Nazli Disman, a fellow at MD Anderson, and Sahil Dosi at Memorial Sloan Kettering are two trainees that are working with us and multiple other institutions around the country to carefully gather clinical data from hundreds of patients with chromophobe kidney cancer. And by combining laboratory findings with patient data, we exactly aim to refine our understanding of how chromophobe kidney cancer behaves, including the sarcomatoid variant, and how best to treat it. And ultimately, we hope that it is these insights that could pave a way for a future where chromophobe kidney cancer therapies, that's what I want to see in 5-10 years, are highly personalized and more effective for each individual.
That brings a lot of hope for patients that hopefully we'll see treatments that are more tailored to the biology of chromophobe going forward in the future, which is exciting. So now I will turn it back over to Annamaria, who I think has been queuing up some questions from some of the viewers.
Yes, we actually have a lot of questions, some of which you guys answered live. So I'm going to, and I've taken care of those, or at least noted that. But thank you so much. Before we get started, the one thing I want to ask, I would love to ask you, Dr. Msaouel, is with the recent budget cuts to cancer research, how might that actually impact all this chromophobe research that's going on at the moment?
Yeah, no, these are definitely challenging times for everyone. And as you could tell, there is momentum for rare kidney cancer research, including for chromophobe. And now, there is a lot of changes and uncertainty that can potentially impact research. We're definitely working hard to maintain our momentum. We're used to working on a shoestring budget. I told you we started working with RMC that essentially got its first ever funding in 2017. So we're very, very good at being efficient with whatever support we have. And in this sense, we do remain committed to exploring all potential avenues of support while ensuring that any support we receive is allocated responsibly and transparently. And cancer, as you guys know, directly impacts the health and well-being of individuals from all walks of life. And we're all united by the goal of improving patient outcomes and eradicating cancer, and we will continue to pursue it any way we can.
Well, thank you for that. I do want to let everyone know that we may not be able to get to all of your questions. Like I said, there are a lot. So we will address as many as we can in the time that we have. And if not, we will have it logged. So that way we can reach out to you if we ever refer to it in a blog post in the future or have another webinar related to that topic. So I think the first one we will go with is for patients who may have negative genetic testing, but a possible family history or other commonalities with known genetic conditions, such as TSC or BHD, are there any additional tests their team may be able to order to investigate any hereditary causes or any differences in management strategies for these patients?
Not really. There's definitely a lot of research going on, including by our group, a lot. And, when we do research, we're very, very, very broad, and we leave no stone left unturned. But from a clinical standpoint, at least in the US, where I know the types of genetic tests that are the panels that are being done, they include, depend on 70, 75 genes or something. They're pretty broad. So from a clinical standpoint, they include all of the things that we essentially know can be associated with chromophobe kidney cancer. So if those tests are negative, then it's unlikely that you will have something else that's really validated, that will find something truly established. Again, research is research. We're learning new things essentially every year. But I think the currently available panels in genetics clinics around the country are sufficient.
Okay, great. Thank you for that. We've gotten a few questions about this, and I think you may have answered during the webinar, but because it's coming in a couple of times, I figured I'd ask, what data do we have on cancer returning after a partial versus total nephrectomy? It's a two-parter. And also, can you talk about other cancers after the nephrectomy, so other primaries?
Yeah, it depends. So it's all trade-offs. When you're removing the whole kidney, that can impact the rest of your life more, because you have less of kidney function. So it's totally depends on the context. Sometimes it is very much worthwhile to do the partial nephrectomy, because the chances of the kidney cancer returning are very, very, very low. So you don't want to just remove the whole kidney for something that will essentially never come back. In other cases, technically, it may not even be feasible to do the partial, even if you wanted to, because the cancer has spread to too many areas. So that's a very, very, very individualized. And so there's a lot of nomograms and guidelines. You can talk with your clinicians, and they can give you those types of trade-offs. And what was the second part of the question? Sorry, I forgot.
The connection between like a nephrectomy treatment or kidney cancer and a second primary. This particular person mentioned melanoma genomically connected to thyroid papillary within 1 year. And as you know, myself, I had papillary thyroid carcinoma after kidney cancer. So I think that's a question I know I get a lot about the second primary. So if you can answer that, that would be fantastic.
Yeah, and again, as it's exactly the same principle, the same general principle. Every time you develop cancer, it's always the combination of these three things. So if, let's say, for example, the reason why you developed your kidney cancer is mainly genes, no matter what you did in your environment, because you had some kind of genetic syndrome, and that genetic syndrome is associated with other cancers, then you're at risk of developing those other cancers. Similarly, if you develop your kidney cancer because of your environment, you were exposed to tobacco a lot, you were smoking a lot and whatnot, and you developed a kidney cancer, you're now as well at risk of developing, lung cancer and other cancers as well as new primaries. And there are, some very rare syndromes that can be associated, because I saw you mentioned, the thyroid cancer, that can be associated with these things. But at the same time, environmental exposures, including tobacco, can also increase the risk for all of this. So it's, again, very, very individualized. But no matter what, it's always, always, always a combination of these three things: genes, environment, and bad luck.
Okay, thank you. Yeah, I feel like the bad luck one is more common than we think. That might just be the cause of everything, if you will. I'm just looking at the stuff that we have here. This is an interesting question that I'd love to hear from you about. Someone asked, what is your opinion on repurposing, the repurposing of medications in the event that all other available systemic meds fail?
Yeah, and we're very, very supportive of that. In fact, we do it. In fact, that's how we were able to develop therapies for RMC. We repurposed other drugs used for other cancers when we realized that RMC was expressing targets that other cancers outside of kidney cancer were also expressing. So we said, oh, they share these things in common. Let's repurpose those cancer drugs. And that's what we did. That is the value of understanding the biology of chromophobe kidney cancer and of other cancers, because that can give us insight of, oh, chromophobe is sharing these potential targets with other cancers, so perhaps we can repurpose, other cancer therapies. It's extremely, 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 extremely rare that you can just repurpose something not developed for cancer and it can work. I wish it was that easy. So, a lot of people ask me about, parasite medications and other things like that. I really, really, really wish it was that easy. It would make my life easier, and I would love nothing more than getting out of a job and then starting, to do my hobbies like physics and astronomy and stuff. But it's not. But we're open to anything. So that's the thing. We will explore anything, but there is a lot of work that we need to put to actually bring things to the clinic that work for patients.
I think, sorry, Annamaria, I was just going to jump in since this one was related. I know we get a lot of questions about supplements and integrative therapies, which I know is kind of along these lines. And you kind of highlighted the importance of when things are tailored to chromophobe, it's really about the biology of chromophobe kidney cancer and making sure it aligns. But as far as when patients may take supplements or do integrative therapies, which we do hear a lot about these days, do they have any potential to hurt in any scenarios? And when is it important for patients to let their physicians know? Do they only let them know about medications that they're on, or also some of these supplements and other items as well too?
Oh yeah, a great question. And yeah, definitely you should let your clinical team know about anything that you're taking. So, some supplements or alternative therapies, they may have benefits, but they can also potentially interact with prescribed medications or have side effects. So that's why it's always best to talk with your healthcare team, especially your oncologist or urologist or the dietitian, all of them, not just one of them. Make sure they all know before starting anything new, to make sure it's safe in your specific situation. A primary care physician as well can offer broad health guidance, but the specialist may be more experienced, like a urologist or a medical oncologist, with how these products could affect your kidney health and your cancer treatments. And ultimately, I would say that transparency with your entire care team is key, so that everyone is on the same page about what you're doing and why.
Okay. Do you have time to answer a couple more, or do we have to?
Yes. It's funny because, in fact, my next meeting is about, rare cancer therapies to brainstorm research. But yeah, we can absolutely spend a few more minutes.
Sure. So one should be a super quick one. One of our listeners cut out when you were talking about recurrence. So they wanted to know, with a larger tumor, does that increase the odds of recurrence and spread?
Yes. The bigger it is, the more likely it has to have spread. But when I say bigger, it's interesting that kidney cancer can get quite big before it spreads. So, you can have something, a tumor that is, 1 inch in size, and then it gets to 1.5 inches, and it's not really that big of a difference in the chances of chromophobe to spread. They have to get bigger than 2.5 inches or 3 inches, to really increase a lot the chances of spreading.
And just to touch a little bit on the nuance there for that too, but the chances of spreading still for small renal masses that say are like under 5 centimeters, it's still not a great increase of spread for those small ones, right? It's kind of
No.
based on the larger sizes there.
Yeah. Again, it's very individualized because there's all these different variables. Like you could have a smaller tumor, but then it could have sarcomatoid changes or necrosis, all these things. But so size on its own does matter, but it's definitely not enough. Definitely. So there can be patients that have seemingly very big tumors and then their cancer never comes back. That's why this is so individualized, and that's why thankfully there are nomograms, there are guidelines on what to expect based on prior experience with other patients with Chromophobe that had this.
Sorry, there are actually a lot of really good questions, so it's hard to pick one that we should stick to. But here is one that just came in related to that point. This has its put, we had a 10-pound with lots of necrosis. Is that high risk?
Impossible to say without looking at the full pathology. And usually, even with RMC, where people know that, I help manage most of these cases in the world, I do that by having the clinicians talk to us directly, because there is so much nuance, and there is so many things that may get missed if we don't know a particular patient's case, that if I just give you, a general recommendation, I may actually be misleading you. So it's unfair to people to just, say specifically for them, this is your risk or whatnot, unless we actually see the patients, or unless their oncology teams tell us, hey, this is the case, this is the question. I do that all the time. I get contacted, including even during this webinar, I got at least 2 or 3 emails for patients with, rare cancers from around the world, where their physicians are asking questions. And that's the best way that we can, help share some of these very detailed knowledge.
Well, thank you for that. I did want to ask, so we have the another question that we had come through in social, on social, was with increasing rates of early onset kidney and colorectal cancers combined with insurance hurdles for early cancer screening and growing environmental factors. Is there anything that patients can do to advocate for earlier cancer screening and more stringent environmental regulations?
Oh, absolutely. Advocate. That's definitely, like what you guys are doing now with this webinar. Educate, including yourselves, advocate, interact with clinicians and researchers like us. We get a lot of great ideas from our patients. The patients are the ones that have skin in the game, so their opinion is very, very, very valuable. So staying active and advocating absolutely helps. Policy decisions are never a one size fits all. There are always, again, different trade-offs, and even patients themselves may have different opinions on, hey, should we regulate this or not do that? But generating knowledge and disseminating knowledge helps regardless. And supporting the generation and dissemination of that knowledge is absolutely helpful, and it can really help make a difference.
Do you know, because I know this is a conversation we've had within the Chromophobe group, but do you know in what drives necrosis? Like what signals make some die so it could be used for drug development?
We're trying to understand it. Necrosis and the different ways that the cancer cells can die can be a very, very complicated field. It requires a whole seminar onto its own, because there's different types of cell death. I'm sure in the Chromophobe community, a lot have heard about one type called the ferroptosis. Liz Henske's group from Dana-Farber in Boston have done some really nice work showing that this is important in Chromophobe kidney cancer. And that has to do with how iron and iron metabolism can affect cell death. How much each of these pathways contributes, and how we can take advantage of it. I wish I had an answer today. If I did, we would have tailored therapies for Chromophobe today, but we don't. But hopefully in the coming years, we will have much more refined answers to that.
And on the lines of research, are you studying ferroptosis? And I don't know if I pronounced that correctly, but there is one of our listeners who's interested in that in their particular case because they've had an aggressive metastasis.
Yeah, we study that and many other things. We keep an open mind because it makes sense also for different groups to explore different avenues, and whatever works, then we pursue that even further. So we're definitely interested in, the ferroptosis pathway and other aspects that are related to the way the cancer cells grow and they metabolize nutrients, and then how they die, so that we can make them die, all of them. So we're very, very interested in exploring many avenues related to that, and we try to be very communicative with sharing that knowledge. So as some of you know, even with CA-125, the renal medullary carcinoma blood marker, we published that paper a couple of months ago formally. Now it's in the public domain in academia, but clinicians around the world have known from us about its use for the past 2 or 3 years. So we very often, if we find something that we think is real and legitimate, which is not an easy thing to do because it's a hard high bar to say this is real, but once we pass that and we feel confident that we can share it with researchers and clinicians so that they can use it to help their patients, we do that even before it gets fully published.
Great. And so we're going to ask one more question or a couple more questions and wrap up. So can you talk a little bit about the tie between immunotherapy and gut bacteria? I know that CBM588, for those who don't know, it's a probiotic strand that is being studied for its potential to improve the efficacy of immunotherapy with metastatic kidney cancer. So what do you know about that? What are you studying about that? Give me all the details you can.
Oh yeah, that's definitely a very, very interesting field. A lot to learn, but definitely very, very exciting. MD Anderson has a very big program dedicated to that across cancers. Nasli Disman, one of the fellows that I mentioned, that is one of our mentees and is working on Chromophobe as well, has a particular interest in this gut microbiome. And in fact, you will see that she led, along with Monty Pal from City of Hope, her major mentor, ever since he came to the US, she led some of these studies. So we're definitely very interested in these possibilities. I think in the coming years, at least some of them will pan out for some cancers. Whether they're really ready for prime time for Chromophobe, they're not right now. Whether they will be in the coming years, time will tell. But again, we're open, we're exploring all avenues, we're intrigued. Anything that can help us activate the immune system to attack Chromophobe, we'll take advantage of it. As soon as we find a signal that something is real, we'll go after it.
Well, thank you so much for that. Now, my last question is, how can our doctors communicate with your group?
Email. Like our email is everywhere. If they do contact us, and if it's something urgent, I often give those physicians my cell phone number if they're in the United States, and it's easy for them to call. But we try to be very, very communicative through email.
That's good to know. And thank you so much, both of you, for this webinar, for this great conversation. It was illuminating for me, being 5 years into this. So I really, truly appreciate the conversation. And again, thank you everyone for joining. As we mentioned, it is being recorded, so we will have this up hopefully within the next couple of weeks for you to rewatch if you need to, or if someone had missed it and wants to catch it. And as a reminder, to all the questions, we have logged them. Sorry if we could not get to yours, there were a lot, but we will reach out if we do answer it in some way. So you make sure you have the information.
Yes, thank you everybody for joining, and thank you, Dr. Msaouel, for sharing this information on Chromophobe with us.
Thank you for having me.